Thank you very much for the invitation to present to this very different group that I'm used to presenting to, a group with all kinds of different backgrounds. So I was going to kind of go through a little bit of what it was like to build a Y90 program, which that's my favorite theranostic treatment, but on my side of the fence, and how we were able to build this program in London, Ontario, and kind of expand that to many centers in Canada. So before we do that, I thought we'd just go through a little Y90 101, since we have a group of different backgrounds. I don't know how many people here are aware of Y90. So Y90 therapy, what does it really involve? So generally it's a treatment for liver and liver cancers, either metastatic or primary liver cancers. And it generally involves kind of these outpatient procedures through interventional radiology, which is my specialty, but kind of involves nuclear medicine, obviously being that it's a radioisotope. So it's kind of a couple of outpatient procedures where I call, the first procedure is what our Google Map Day, where we kind of map out people's liver and map out these liver cancers within their liver through the arteries, because they tend to be hungry tumors that tend to be fed by the arteries themselves. So we do a liver angiogram, and we deliver a kind of Y90 surrogate with technetium macroalbumin and do this kind of lung shunt study. And then we use that information along with their CAT scans and these specialized software to calculate a dose of radiation and bring them back a week or two later for a therapy day. And on that day, we also do kind of this minimally invasive procedure, an angiogram, and deliver these radioisotope via these millions of these tiny little beads. So what does that look like in real life? So this is a person who happen to have liver cirrhosis, and people with liver cirrhosis are screened for liver cancer. So in order to kind of walk you through this, you kind of have to become an interventional radiologist or at least a radiologist, and we can sort of label this. It's kind of like we're cutting you up like a piece of salami, and we can see that big gray organ there is the liver, okay? And within the liver, we see a spot that was detected on an ultrasound and got further workup, and that in fact is a small liver cancer. The unique thing about liver cancer, doesn't need a biopsy. We're able to make that diagnosis based on the imaging alone, which is unique to liver cancer, and we're able to treat him accordingly after a kind of a multidisciplinary discussion. In this particular patient, we're gonna bridge him for a liver transplant. So this is what an angiogram looks like. We've subtracted everything from the image. It's called a subtraction angiogram, and all that we see is the black blood vessels that we've injected X-ray dye into. And you kind of have to imagine with me that in fact, we're seeing a blush or a tumor blush, of which I kind of navigate and do a little bit more of what we call a super selective angiogram, getting right up to those blood vessels that are feeding the tumor. And you can kind of make out a little circle there that I've delineated with the arrows, that in fact is the small liver cancer itself. We do a fancy picture on the radiology side. So, my colleague, Duncan Sutherland may not be as excited about the black and white, but then I threw a little color in for him. And in that little cone beam CT where we really are right up to where the tumor supply is, we inject a little bit of that technetium, and we can, it looks like a little piece of pizza with a large piece of pepperoni being the cancer, and the rest of the pizza being that little piece of normal liver. We use some fancy dosimetry software, and we're able to repeat the process and treat the patient. And I'll show you a couple more examples later than that. So how did we get started in London? Well, in the Canadian healthcare system, those of us that work in the system, it's a constrained system. So starting clinical programs can be very difficult. But we'd already been quite successful in London, expanding some interventional oncology programs, doing things like radiofrequency ablation, microwave ablation, cryoablation. These are different technologies to treat solid tumors in different organs. And we even were doing some transarterial therapies similar to Y90, but not Y90, things like chemoembolization, where instead of injecting radiation beads, we were injecting chemotherapy into the liver arteries. So one of my colleagues said, hey, why don't we start doing Y90? And I thought, man, we're already getting gray hairs and losing hair starting these other programs. And I thought, you're crazy. What are you talking about, starting another clinical program? But I went along for the ride. The two of us, along with an IR technologist, a nuclear medicine technologist, physicist, and a nuclear medicine doctor, went to Chicago, which is kind of the mecca of Y90, and we ended up treating our first patient in 2013, which sadly was a physician colleague who happened to be our first patient. And we sort of pleaded with our department, said, hey, can we make an exemption to treat this individual? And luckily they granted it. And around the same time, the company that one of the Y90 companies sort of was offering up free doses I called it a little bit of the crack cocaine approach to medicine, where they gave us the first few doses for free. And so they kind of agreed to about 5 doses a year between the department and the company, and we were able to start this fledgling program. But not soon afterwards, not shockingly, they said, no more free doses. And our department said, yeah, this was a bad experiment. We want to stop doing Y90. But luckily, one of my medical oncology colleagues had a document for PRRT where we had the patients had option to do self-pay. So we tried to revamp this for Y90, presented it to our imaging department, and they very reluctantly agreed to start a self-pay program, which is very kind of against the fabric of our Canadian nature to offer a self-pay program for oncology, but it kind of already exists in reality, right? People are paying for certain oncology drugs, you know, that are outside the quote-unquote standard of care, so we thought, let's try this. And BTG and then ultimately Boston Scientific was supported by throwing in the occasional free doses. It wasn't quite buy one, get one free, but you know, we were sort of operating with a few free doses here and there for people that didn't have the means. But it was uncomfortable, right? It was uncomfortable having that conversation with people. People felt like, hey, I'm paying for it. I want you to guarantee results. And we all know that cancer therapy doesn't quite work like that. We had some individuals that had really innovative ideas, crowdsourcing or crowdfunding, things like that. But you know, ultimately, it was still a very uncomfortable conversation, about $20,000 per treatment, which in Canada, you know, that's cheap. If you cross the border into the US, it's a much higher cost, but still $20,000. You know, if I polled the audience, how many people have $20,000 sitting in their back pocket? Probably not that many. But I had the patients also call, make noise to their MPPs. Why do I have to pay in Ontario? Whereas if I'm in BC and Alberta, we don't have to pay. We did some press, some videos to kind of create awareness. And it kind of caught CCO's attention over the next few years. And ultimately, as of 2021, it got funded for very few indications, which was great. So this was kind of a video that we did, and I'll show you one of the patients that we featured in the video. Much younger guy with full black hair, you know, and then building Y90 gave me a lot more gray hairs. So we were able to get this provincial funding, which was massive. That was a huge, huge win in Ontario, and a huge win in Alberta, a huge win in Quebec, that we're able to fund for these very limited indications. But still, that's something is better than nothing. There certainly are some things missing, which I'll talk about later, but hey, we got to win, at least for the major indications. So where are we currently in London? Well, right now we have this very robust, committed, multidisciplinary team supporting the Y90 program from IR, from nuclear medicine, medical imaging, as well as our leadership within the hospital. We have a very strong multidisciplinary team, cancer team, in terms of, you know, surgeons and oncologists and, you know, nuclear medicine docs and all kinds of different specialists for both liver cancer, metastatic colorectal cancer, neuroendocrine cancer. And then this program in London really led to a lot of center of excellence events in partnership with Boston Scientific, where we were able to train the vast majority of the centers across the country, and not just the physicians, but we were able to train technologists from nuclear medicine, from radiology, nursing, leadership, because this is a very labor-intensive program, really advocating for, you know, this program, for the logistics, as well as doing the advanced dosimetry, and really positioned our program in London at the forefront. Not just myself as a physician, but even our nuclear medicine technologists, our leadership people, they really, their expertise was really widely respected. So our volumes, as you can imagine, once you hit, you know, this is in the fledgling years of people paying, and then the moment, which is still pretty impressive, people paying out of pocket, but once obviously we got that provincial funding, our volumes have shot through the roof. In terms of future directions, obviously we're going to keep doing what we're doing. It's working very well, and really selecting the right patients in our multidisciplinary team that are good for Y90, and we're generally using it as a bridge to liver transplant or to downstage primarily, and then less so in the smaller spaces of colorectal and neuroendocrine. I want to push to even expand our indications to things like cholangiocarcinoma, metastatic breast carcinoma, and in the Y90 world, we're really moving outside the liver. We're one of 2 centers in the world, actually, that's looking at it in kidney cancer, and there are people looking at it in the brain and in the lung, and so it's really starting to expand outside the liver. Just to show you a couple of quick examples of cases that have really changed the trajectory of my career and my practice. This was a gentleman that I saw early on our Y90 when we were getting those free doses. A gentleman who was 75 years old, who happened to have, you know, NASH cirrhosis or metabolic cirrhosis, but very well compensated, so was just being screened by his doctor with routine ultrasounds, and they found an incidental finding that warranted further investigation, and ultimately ended up getting referred locally in London for a surgeon who discussed him at our MDT. So it was a really, just like a charming fella, okay? So he was featured in our video, so I have his permission to show his picture. And he was just like such a interesting guy, came with his family, his daughters, his grandkids. You know, I always find when people come to your clinic armed with a whole bunch of people, you know, it kind of touches you that this must be, so this is someone that people care about, you know? And I'll tell you, I don't know if I've worked with a lot of Italian Canadians in my life, and nothing gets them more excited than talking about their garden, you know, and this man loved to talk about his tomatoes. And you know, when I saw the picture of this, I thought, geez, I see why. And so he was very passionate about his garden and his grandkids. He loved driving around in his tractor. And so to bring it back to the whole Y90 piece, you know, he had this orange-sized tumor in his liver. You know, and you can see, hopefully I've labeled this like he's standing in front of us. So you can see the liver, and you see he's got this big spleen that's a consequence of cirrhosis. And so the treatments that I had at the time aren't necessarily going to cure him. But with the Y90, the advantage is, so this is what his angiogram looked like. You can see this big vascular ball, right? So this tumor is hungry, and it's hungry for some radiation beads. So this is the kind of case when I see, I'm very excited to treat because I know I can make a real difference on this one. And just to throw some colorful pictures, people get bored with the black and white. So this is what, you know, we image these people after the Y90 with either with SPECT CT or PET CT to be able to, you know, detect that radiation that they're emitting. And it was nicely kind of nestled in this tumor. And over time, you don't have to be a radiologist to see that in the very top corner, you see this big enhancing tumor there in the back. And over time, it's completely melted away within 2 years. So radiation does take a bit of time, but then it was gone. So this guy had a complete response, cured. You know, I can't do that with the other treatments that I have for that size of a cancer. And so he developed another small liver cancer that I was able to stick with a needle and barbecue. And really, he passed away in his early 80s. And if we did not intervene, I can guarantee you that would not have been the case. So that was a really great feeling. And this is one of the cases that keeps me going, you know, for my career. I'll never forget this person. They may forget me, but I'll never forget them. So this happened to be a young woman who had immigrated from China and was pregnant. And during her obstetrical ultrasound, the ultrasound technologist discovered something quite ominous. So they were looking at the baby, and sometimes you get a little too high and you get up into the liver, and she saw this huge liver mass on this 34-year-old woman who happened to have hepatitis B. Not cirrhosis, but just happened to have a history of hepatitis B. And so this is a CAT scan at the time of her diagnosis, and there's like a grapefruit in there. There's a very big tumor occupying a big chunk of the right part of her liver. Hopefully you guys can see it delineated there. And she had this tumor marker, so this protein that's secreted in her blood that was very high, 34,000. To give you context, 200 is kind of considered high or abnormal. 34,000, that's very high. That's a sign that this is an aggressive cancer. So she was brought by one of the community liver surgeons who thought, I'm gonna chop this thing out and we're gonna try to cure her. But we know when we do that, her long-term outcomes aren't great. There's a very large chance of recurrence. So we thought, why don't we try, let's try to get this lady. She is not a transplant patient right now, but let's try to use this Y90 therapy to downstage her to a liver transplant. So aggressive tumor, she actually developed metastases to her lung during this workup. So it was quite scary, and that 1-year survival in this particular person is quite low. But we went ahead and treated her, okay? I actually had to treat her twice. And so one way to follow her is with the CAT scan. The other way is just with these tumor markers. So the tumor marker went very low to 12, from 34,000 to 12, which that's the exact direction we want to go, and 12 is basically normal. We were able to downstage this person. She went on to have a liver transplant, and is basically about 4 to 5 years ago doing well, enjoying life with her family. So this is the kind of person that we want to treat with this type of therapy. And to think that a year or two before I met her, it would not have been funded, and there's no way she was paying out of pocket. And that, you know, my part in this patient's care was an important one, but it was not the be-all, end-all. I had a part. The liver surgeon had their part doing the transplant. The hepatologist had their part following the patient, treating the hepatitis B. So it really highlights the importance of this multidisciplinary collaboration. So we try ultimately put that patient in the center and have all these medical specialties around, not fighting over, hey, it should be me, not you. Really, how can we all, participate in the care and optimize outcomes? Also, apart from the docs, it really takes a village with the Y90 program. We have this multidisciplinary team of nurses, of technologists, both on the IR side, on the nuclear medicine side. We have even our administration assistants who really quarterback these programs, contacting the patients. There's a lot of coordination involved. Our physicists, our administration, our leadership. This really takes a village. So in summary, the Y90 program at Western has really seen tremendous growth, and it's played a very large part in the provincial funding piece. I think it's an amazing technology. It's really changed the trajectory of my career, and I feel like we've had a very positive impact on patients and a great benefit to patients. And it's really a multidisciplinary program and has been a great physician industry partnership with Boston Scientific for a lot of the knowledge translation. So thanks for your attention.